So now we will talk about small bowel diseases. This image shows Giardia, probably the first microorganism visualized under the microscope. The image you can see the typical clown face appearance of the parasite. The following are pathologies affecting the small bowel. Congenital anomalies, like Meckel's diverticulum, which is typical of young age, ischemic disorders, mostly elderly with atheromatous disease, but also those affected by vasculitis, malabsorption, so celiac disease, genetic defects like disaccharide deficiency, autoimmune diseases like celiac disease and others, Crohn's disease, infectious enteritis, drug enteritis, chemoradium-induced enteritis, graft versus host disease. Neoplastic diseases, like the small bowel has a really low frequency of neoplasms, is a quite strange phenomenon since the small bowel is one of the most rapidly dividing tissues, so we have a very high cell turnover. In 4 days it completely renews itself. We have lymphoma, which is the most frequent type, some related to celiac disease, some to Crohn's disease, especially in immunosuppressed patients. We have adenocarcinoma, which is very rare, and the carcinoid, a NET, which is a neuroendocrine tumor typically localized in the ileum and well differentiated. Infectious enteritis are the most common causes of mortality among the previous diseases, especially in children and in underdeveloped countries. More than 1 million people per year die from GI infections. Most, most enteritis are actually gastroenterocolitis and not circumscribed to the small bowel. We can have a viral enteritis due to norovirus or rotavirus. Norovirus is a single-stranded RNA genome that forms a genus with the Caliciviridae family. It causes approximately half of all gastroenteritis outbreaks worldwide and is a common cause of sporadic gastroenteritis in developed countries. The rotavirus um, is an encapsulated virus with a segmented double-stranded RNA genome. It infects 140 million people per year. It causes 1 million deaths each year. It's the most common cause of severe childhood diarrhea and diarrheal mortality worldwide. Children between 6 and 24 months of age are the most vulnerable. Before 6 months, there are still some protective mechanisms acquired from the mother. We have bacterial enteritis, so Whipple's disease, and protozoal enteritis, Entamoeba histolytica, which is an enterocolitis diffused in developing countries and easily acquired by travelers to these areas. Probably also in Italy there are some endemic areas. So we have protozoa that causes amoebiasis. It's a protozoa. It is spread by fecal oral transmission. It infects approximately 500 million people in developing countries, and it causes 40 million cases of dysentery and liver abscesses annually. And we have also helminthic enteritis. So bacterial, viral, norovirus, rotavirus, bacterial, Whipple disease, protozoal, Entamoeba histolytica, especially, and helminthic enteritis. So Whipple disease. It's a rare multivisceral chronic disease. Okay. Whipple's original case report described an individual with malabsorption, lymphadenopathy, and arthritis of undefined origin. Post-mortem examination demonstrated the presence of foamy macrophages and large numbers of argyrophilic rods in the lymph nodes, providing evidence that the disease was infectious. The gram-positive actinomycete, named Tropyreman whippei, that is responsible for Whipple disease, was identified by PCR in 1992 and finally cultured in 2000. This is a very fastidious bacterium to grow in culture. Clinical symptoms occur because organism-laden macrophages accumulate within the small intestine lamina propria and mesenteric lymph nodes, causing lymphatic obstruction. Thus, the malabsorptive diarrhea of Whipple's disease is due to impaired lymphatic transport. The clinical presentation of Whipple disease is usually a triad of diarrhea, weight loss, and malabsorption. Extraintestinal symptoms, which can exist for months or years before malabsorption, include arthritis, arthralgia, fever, lymphadenopathy, and neurologic, cardiac, or pulmonary disease. It can be misdiagnosed as multiple sclerosis or a cardiac condition. These manifestations are all due to the fact that the organism infects and accumulates in macrophages, which then accumulate in different organs and tissues and lymphatics, causing obstructions. Patients with extraintestinal presentations typically have a long and debilitating course. Treatment is long-term course antibiotics. So we see macrophages in lamina propria, mucus-producing goblet cells filled with glycoproteins, lamina propria filled with macrophage filled with Treponema whipplei, and Tropinema whipplei. Anyway, inflammatory bowel disease. We can have Crohn's disease, ulcerative colitis, and undetermined chronic inflammatory disease. Organ-specific immunologic diseases with acute and chronic phases. There are organ-specific immunologic diseases with acute and chronic phases of mucosal damage, intermingled with phases of remission and regenerative phenomena with remodeling of intestinal mucosal architecture. There are frequent diseases, so incidence is high, prevalence is higher since it's a lifelong disease. The main pathogenic mechanisms are, at least in part, shared between Crohn's disease and ulcerative colitis. We have chronic immunologic diseases, abnormal immune response to environmental factors in subjects with predisposing genetic habitus, so there is some knowledge on genetics aspects but still limited, while there is nothing yet on environmental factors. The etiology is unknown, so there are several hypotheses. Can be infectious, so persistent specific infection acting as trigger. We have dysbiosis, so abnormal composition of the intestinal microbiota, that is abnormal ratio between beneficial and detrimental commensal microbial agents. We have defective mucosal barrier function, defective microbial clearance, and aberrant immunoregulation. There is no cure. So these are the main common features: chronic immunologic disease, abnormal immune response to environmental factors, etiology unknown, and there is no cure. The GI immune system is always exposed to massive concentrations of different self and non-self antigens, which are continuously changing. It must be constantly working in control and modulation to achieve good defense together with tolerance. It must reach a healthy balance between them. The mechanisms involved are extremely complex and beyond the scope of this course, but the main players are IL-23 and Th17 regulatory response. The central challenge of the intestinal immune system is balancing defense with tolerance. Defense with tolerance. Responding to pathogens while coexisting with resident bacteria and food antigens. This regulation in either direction can result in intestinal inflammation. IL-23 Th17 pathway genetic associations have been identified in both as Crohn's disease and ulcerative colitis, as well as other autoimmune disorders manifesting in tissue inflammation. These discoveries emphasize the importance of proper regulation of this immune pathway. There is a dynamic cross-regulation between Th1, Th2, Th17, and Treg pathways. The proper balance is critical for optimizing defenses to microbes while simultaneously avoiding chronic tissue inflammation. So, we have defense and tolerance. The most frequent alterations observed in IBD patients are related to genes controlling these immunologic mechanisms. CARD15 node 2, they are the main genes involved in which is the main gene involved in Crohn's disease pathogenesis. It modulates NF-kappa B activation and regulation. NF-kappa B activation is frequently a downstream effect of several infectious agents. We have IL-23 pathway, so IL-23 receptor Th17, myosin 9B, and NLRP3. Due to the great genetic predisposition of Crohn's disease and ulcerative colitis, there are several studies on the genetic map of these diseases. Several gene polymorphisms have been detected and are called with an IBD designation. The genetic predisposition is especially strong in Crohn's disease rather than in ulcerative colitis. Some of these are characteristic of either one of the other inflammatory bowel diseases, while others are shared among the two. Another two is specific and for the most relevant alteration in Crohn's disease. Cytokine profile, so we see here different mutations, more different profiles. The cytokine profile is especially relevant for therapeutic purposes because it's different between Crohn's disease and ulcerative colitis. In Crohn's disease, the main cytokine is TNF-alpha. Thus, one drug used is infliximab. TNF, so one drug used is infliximab. Node 2 is Node 2 Crohn's disease associated human Node 2 variants exhibit reduced capacity to activate NF-kappa B following MDP, which is muramyl dipeptide stimulation. Node 2 deficiency is associated with reduced production of TNF-alpha and IL-6 and lethality after systemic infection with E. fecalis despite normal bacterial loads. Okay, it's important to underline the fact that inflammatory bowel diseases are frequently associated with other autoimmune diseases, such as rheumatoid arthritis and SLE, so there is a shared genetic background among them. You see here sharing with multiple sclerosis, systemic lupus erythematosus, ankylosing spondylitis, psoriasis, BC, alopecia, asthma, type 2 and type 1 diabetes mellitus, celiac disease, vitiligo, leprosis, atopic dermatitis, and rheumatoid arthritis. A very simplistic model is that in normal gut tolerance mechanisms control inflammation triggered by external antigens. So in the presence of an environmental trigger, like an infection or drug, there is an acute inflammation. When the trigger is cleared, the immune system can either go back to tolerance and lead to complete healing, or it can enter a loop of chronic inflammation if there is a defect in the system, so a lack of bacterial clearing or decreased regulation in a genetically predisposed individual. So you can have normal gut, environmental trigger leads to acute injury and acute inflammation. Then we can have tolerance, so complete healing, or decreased immune regulation, failure of repair, or bacterial clearance. So in a genetically susceptible host, we have chronic inflammation. It's very important to understand the pathogenic mechanisms in order to achieve the best possible therapeutic approach. acting on bacterial flora with probiotics or genetically modified bacteria, using anti-inflammatory and immunosuppressive approaches. So the drugs listed above are the main ones used in IBD, but it may be necessary to use more aggressive therapies. Immunomodulatory therapies provide a more aggressive and or targeted treatment. Crohn's disease. Crohn's disease is mostly a Western country's disease. It has an incidence of 8 over 10, 100,000. The onset is usually in the second decade of life. It's often familial, with 30% of patients having an inactivating mutation of not 2 card 15. The macroscopic features are involvement of the terminal ileum, so terminal ileitis, segmental ileitis, parietal thickening, stenosis caused by the wall thickening, adhesions due to transmural inflammation causing also serositis, fistulae, probably there is some genetic predisposition to fistulae formation in a subgroup of Crohn's disease patients, and mucosal ulcerations, so cobblestone appearance, which is common. You see wall thickening and mucosal alterations, cobblestone appearance. The ileum is the main site involved, but 20% have large bowel involvement, especially of the rectum and anus. At the microscopic level, it's possible to see alterations also in the gastric, esophageal, and oral mucosa, the latter presenting frequently with multiple recurrent aphthei. The stomach can present with all the typical lesions. Sometimes it's possible to see granulomas, but also in apparently normal mucosa, there is a pattern called focally enhanced gastritis. It's in a normal mucosa, there is a small focus of inflammation, not granulomatous, but very confined granulocytic infiltration destroying the glandular structure, which is especially relevant in the pediatric age. There are other extraintestinal symptoms and associations with autoimmune and allergic diseases. There are several microscopic features, none of which are specific, but if present together with the classical clinical appearance, they are highly suggestive of Crohn's disease. We have superficial erosions, like aphthous ulcers, aphthous erosions, crypt abnormalities, acute and chronic inflammatory infiltrate, cryptitis and cryptic abscesses, pyloric metaplasia, which is a sign of continuous damage and remodeling of the mucosa, edema and submucosal fibrosis, neuronal and muscular hypertrophy, transmural lymphoid infiltrates, so formation of tertiary lymphoid structures, fissuriform ulcers, and granulomas present in only about 30% of patients but are extremely characteristic and reliable diagnostic hallmarks of Crohn's disease, especially with respect to ulcerative colitis. Usually, a patient with Crohn's disease does not undergo surgery unless there is a complication requiring it, such as stenosis. So you see here inflammatory infiltrates, submucosal edema, erosion of the luminal epithelium, and large lymphatics and vessels. In Crohn's disease, there is an increased risk of neoplastic transformation, with an increased incidence of adenocarcinomas and lymphomas. The latter are mainly due to immunosuppressive therapy and are mostly associated to ABV. Adenocarcinoma incidence is increased, but is still very rare, while colon adenocarcinoma incidence in ulcerative colitis is extremely high.